behalf of my team on the second day of Brain Awareness Week, an initiative by International Brain Research Organization, Dana Foundation, and Federation of European Neuroscience Society. I am Vyoma Shah, the co-organizer of this event, a master's student of neuropsychology, and the moderator for this event. It's the last session of the day, but I hope you have the same level of enthusiasm to know more about your brain. All of us either know someone or are that someone who has cracked their bone in their life. But did you ever wonder what exactly is happening in your brain at this point in time? Well, with us today, we have Dr. Shah, a joint reconstruction surgeon practicing in Mumbai at Jaslok Hospital, Kambala Hill Hospital, and St. Elizabeth Hospital. He specializes in joint replacement surgery and has been trained in countries like South Korea, UK, and the USA. He is also a tutor for Masters of Surgery program in University of Edinburgh, UK. Dr. Shah will be sharing his knowledge in joint pain, joint replacement surgery, and how does your brain respond during this entire process. The topic is joints and your brain. What's the connection? So I request you to lead us into the session.
Thank you very much, Miss Vyoma. I'm very glad to be a part of the Brain Awareness Week. Thank you very much for having me on this platform as well. Diving right into the topic, it's a topic basically which works on joints and the brain. Most of us at some point or the other have had some issues with joints, or we have known someone who has had some issues with joints. But how does that connect with our brain? Before we know about that, let's just understand about the anatomy of a joint and what a joint basically is. A joint is basically a connection between bones. It may be two bones or three bones, but there's a connection between bones. Movement occurs at the joint. Joints are covered by a capsule, which is actually a tough fibrous tissue, and stabilized by ligaments, which are also tough fibrous tissues. The capsule and the ligaments, they function to hold the joint in place and keep it stable. The bone ends of the joint are covered by a cartilage. The cartilage is this white shiny structure. I hope you can see with my pointer that it basically covers the ends of the cartilage, and it allows for the smooth movement of the joint. In some cases, this cartilage is covered by synovium, which gives out a fluid called a synovial fluid, which helps to lubricate the joint, nourish the cartilage. Movement across the joint is facilitated by the muscles which cross the joint. Now, these muscles may cross on the front, back, or the sides of the joint, take part in various movements of the joint. The nerve supply from these muscles goes to the brain, and they get the command from the brain as to how they need to act. So the nerve supply in a joint. Now, the joint itself has got two types of nerve supply. It's got a sensory nerve supply, which basically gives the sensation to the joint. Now, what sensations are felt by a joint? It feels pain and proprioception. Pain we understand, but what is proprioception? Proprioception is basically the position sense of of our joint in space, and how we are moving, how we are in a posture, how we are controlled, where our joints are in space. This also helps in posture and balance maintenance. The joints also have a sympathetic nerve supply, which basically supplies the blood vessels around the joint, and it monitors and changes the blood flow to a joint. Now, these sensations that a joint feels, how does it feel and what helps it pick up these sensations? This is done by what we call as receptors. Receptors are basically a group of specialized cells which are located within the structures in and around the joint. As you can see in the picture over here, so we have various types of receptors in a joint. You have the Golgi complex, Paciniform, and Ruffini endings, which work with movement and sense of balance. And you have got nociceptors, which are basically your free nerve endings. Nociceptors are what pick up the pain sensation. These are involved in how the joints perceive pain and how they pick up the pain. The joint function. Now, the joint has two very basic functions, very simple functions. Remember, movement and position sense. They help the body move, they help the joints move, they help your arms, legs move and take you from point A to point B. And they give a sense to the body as to how you're placed when you're in a particular position. Now we come to the brain. The parts of the brain that are connected with movement, it is to do with the motor cortex. Now all voluntary movements of the body are controlled by the motor cortex. Now, where is this motor cortex located? It's located in the rear aspect of the frontal lobe. The frontal lobe is what is basically in the front of your brain. Now, assume this to be the forehead and this to be the back of your head. This is the frontal lobe and this is the motor cortex. This is divided into two parts, area 4, which is the primary motor cortex, and area 6, which is the premotor cortex. All the commands to the body to carry out voluntary movements generate in these two areas. But to carry out these movements, it first needs to get input from various parts of the brain. So for example, the sense of where the body is in position comes from the parietal lobe. Visual sense comes from the occipital lobe. If you have done a particular movement in the past, it is saved as saved as a part of a memory, and that comes from the temporal lobe. And the main lobe here is the frontal lobe, which basically understands what movement needs to be done, makes a plan, and decides what needs to be done and relays that information on to the motor cortex. Now, this is a motor map. Now, assume that you are seeing a cross section through the brain at the motor cortex. So we're looking at area 4 right now, and there's a section through it, and every part of the body is represented on this motor cortex, where you can have any voluntary movement. So you have the foot, hip, trunk, all the way to the tongue. The more central parts are lower in the body, so the foot comes actually in the center of the brain, while outer side you have the face and the tongue. You will notice that the area given for the hand is almost the same as the area for the lower leg. So hand is a very small part of the body while the leg is so big. But that's because hand does a lot of fine movements, a lot of complex, delicate movements for which it is given a very large area on this map. Next we come to the basal ganglia. Now the basal ganglia works along with the motor cortex. What is the basal ganglia? It is a set of 3 neural structures tightly connected, situated deep within the cerebrum. Cerebrum is your brain. This basal ganglia, the job of the basal ganglia is to receive information from all parts of the brain and pass it on to the motor cortex. What it does, it selects and initiates the movement and helps in coordination of those movements. Think, for example, a patient who suffers from Parkinson's disease. Now, this patient has got a problem with the basal ganglia. And these patients, if you have seen them, they find it very difficult to initiate a movement. They find it very difficult to control their movements or to perform actions. Next, we come to the cerebellum. Now, the cerebellum is a small part located here beneath the main cerebrum. Cerebellum works as an internal clock to the entire brain. It is the part of the body which maintains our balance, our posture, and it's the part which coordinates all actions which are generated in the brain. So, for example, you want to pick up a glass of water which is kept near you. The direction in which your hand will move, the force with which you will hold the glass, the speed with which you will move, and how much time is going to take you to do that is all controlled by this cerebellum. Think of a person who has consumed a lot of alcohol. Now the alcohol has a direct depressive effect on a cerebellum. It slows down the functioning of this particular part, and you see a person who is drunk, you ask him to walk in a straight line, and he just can't do that. That's because of the issues with the cerebellum in these people. In a normal person, it will control the speed, force, direction, and duration of your movement. Now, all these three things put together are the part of the brain which will control your movements. Now, in the next slide, we will see what we call as a movement pathway. So, how do the joints and the brain work together, work as a unit? Think about this leg and you want to straighten your knee. You want to make your leg straight. That, um, that request goes from the knee to the spinal cord via nerves. In the spinal cord, it meets other nerves. It transmits its message forward, which is then taken up via various tracts. Now, tracts are groups of nerves which take up the information from the spine to the brain and relay it back from the brain to the spine. So the information is sent via these tracks from the spine up to the brain. As we have seen in the slide before, it goes into all parts of the brain, frontal, temporal, lobe, etc. There is a plan made of what action needs to be carried out for us to straighten that leg. That information is relayed back to the spinal cord via tracts and sent back via nerves to the leg, and then we straighten our leg. We do it in a fraction of a second, but the entire process is going on during that time. Now, we have seen about the joint, how the joint functions, and a bit about the brain which controls joint function. But when the joint comes in trouble and the joint is not happy, how does the brain know about it and what does it do? So pain is one of the commonest symptoms associated with every joint problem. Now, what is pain defined as? Pain is defined as an unpleasant sensory experience and also an unpleasant emotional experience which has been caused by tissue damage. So anything which will cause harm to a tissue in the body will lead to an unpleasant experience which we pick up as pain. The body picks it up via receptors. Receptors, as we've seen earlier, are a group of cells which pick up these sensations. So these pain receptors are present all over the body and they pick up these sensations and transmit it forward to the brain. Now, all the tissues in the body don't react in the same way to every stimulus. So, for example, if you take a knife and you cut a skin, you will feel pain. But with the same action of cutting, if you do it in any of our internal organs, you will not feel any pain. Rather, if those same internal organs are stretched or subjected to some noxious chemicals, then they will distend, they will get irritated and feel pain. Pain is mediated via these two fibers here. It's the A delta and the C type fibers. These are the smaller fibers. The larger fibers, A alpha and A beta, are the ones which transmit the stimulus of movement and position sense. The pain pathway. It's very simple to understand the pain pathway. Assume you're getting pricked by a pin in your finger. You've got pain receptors in your finger, nociceptors. They get stimulated. There is a impulse generated which transmits up via the nerve to the spinal cord. In the spinal cord, we have seen that there are many connections. The information gets passed on forward to the brain. It gets picked up by the small region here in the brain, thalamus. Thalamus is like a relay point. It gathers the information and then decides that the sensation of pain has to be passed on to somatosensory cortex, and the sensation of the unpleasant feeling goes to the limbic system, and the thought process involved with all this goes to the frontal cortex. So that in gist is a pain pathway. Now, joint pain. We can't really put a needle inside a joint and prick someone, can we? So how does a joint feel pain? Joints, with the basic function of movement, will react to any mechanical stimulus. There are free nerve endings, like we've seen in the slide before, which are the nociceptors or the part of the joint which picks up pain. These free nerve endings are located in the capsule ligaments, in parts of the bone, etc. Now, these free nerve endings, what they do is they get excited or they get stimulated when there is a mechanical stimulus. When there is any mechanical stimulus, they get excited, other nerves get excited, and the information is transmitted to the brain, showing that this is a mechanical stimulus to a joint. Now, if it is a painful mechanical stimulus, then the rate of firing of these free nerve endings goes up dramatically. There is a bombardment of sensations to the brain, which is perceived as pain. Along with this, along with this particular theory of pain in the joint, if you have any injury in the joint, there is a swelling in the joint, stretching of the joint, and there's a lot of chemical mediators which also excite these same free nerve endings, and these are picked up as pain by our brain. This information from the joint, from the free nerve ending, travels via the nerves to the spine, as we have seen earlier in the pain pathway, and by the same tracks goes up into the brain. Instability. Now, this is another aspect when a joint is in trouble. One of the main functions of the joint is to keep is to be stable so that we can have a normal movement and we understand how the joint is moving in a particular space. But you see, after an ankle sprain, it sounds so easy, sounds so simple. Ankle sprain, we've all gotten it at some point. But some patients or some people, for example, they heal very quickly after an ankle sprain because they have a mild sprain. Some have a severe sprain. After the healing, some people still feel unsteady on their feet. They still feel that they're wobbling. While if you examine the joint, they seem to be very stable. But it's a subjective feeling of instability, which is a functional ankle instability. And this occurs because the proprioceptors, that is those small nerve endings in the ligament, which pick up joint sense and movement sense, they get damaged in the process of the injury. Because of that, because of the damage to them, and they may not heal completely, or they may convert to pick up. They may convert themselves to get stimulated by different um, stimuli than what they normally should be. Because of this, they tend to leave us with a feeling of instability. What happens in the brain at that time? There is cortical remapping in the brain. So there is rewiring of our brain because of what's going on in the joint. And in some people, this remapping makes stronger connections, so you heal very well. And in some people, it makes very poor connections and you are left with instability after an ankle injury. Coming to the knee. Now, the anterior cruciate ligament, we all must have probably heard about it at some point. Many of us have had an injury of the ACL or known someone who has had an injury of the ACL. This is a very strong ligament in the center of the knee. It controls the knee, does not allow any awkward movement in the knee joint. It's also very critical for proprioception from the knee perspective because it has a large number of proprioceptive receptors. Again, some people who have an ACL injury, maybe a mild one or a severe one, heal very well and some don't. That is again by the same concept of neuroplasticity as we've seen earlier and the cortical remapping which goes on in the brain and the damage to the proprioceptors on this particular structure. A large number of studies have been done which have studied this phenomena, seen people who have got ACL deficient knees or knees with a tear in the ACL. They have put them in a scanner. They've asked them to do simple movements of bending and straightening the leg, and they have seen that there is altered cortical activity in various parts of the brain which should not be there. It's also seen that because of the lack of the sensory feedback from this particular ligament, there is lack of a coordinated muscle activity, which is enhanced by the cortical remapping, and there is functional instability. As doctors, we use this information in this particular case to improve the patient's condition by performing a surgery and following a focused physiotherapy protocol, which helps them recover better from this injury. Similarly, in the ankle, they need to have a focused physiotherapy set of exercises which focuses on proprioception and balance to help them recover. Now coming to arthritis, pretty much everyone either knows someone or has has someone in the family who has this problem and is suffering from this problem. What is arthritis? It's a degenerative process. It's a disease process in which there is inflammation, degeneration in the joint. There is breakdown of various structures of the joint. There is instability, and there is pain in the joints. The main symptom, the hallmark, is pain. Cartilage breakdown is the end stage of all types of arthritis. There are over 100 types of arthritis. Arthritis itself directly is a significant contributor to increased morbidity and mortality in patients. The slide isn't loading. Sorry, just a minute. Yeah. So patients who suffer from arthritis, they have chronic pain. Chronic pain is basically pain which lasts over a long duration of time. This is pain which stays with them for a long time. But why does that happen? It is because of the disease process. Because of the disease process, because of the neuroplasticity going on in the brain, and along with that, the changes in the joint itself, which leads to this chronic pain. There is this concept of silent nociceptors. Silent nociceptors are again free nerve endings which remain silent for most part of your life. But when there is an injury, they start firing, and even in a resting state, because of various chemical factors, they keep on firing, and you get rest pain, which is one of the features in patients with arthritis. These people also undergo peripheral sensitization, which means the joint gets sensitized. The free nerve endings, they get sensitized. They start firing very easily with minimal stimulus, and show a hyperactive response. So the joint is very active even for a small amount of stimulus. Peripheral sensitization is mediated via chemical and mechanical factors in the knee joint. In this slide over here, this is just a small picture, which shows a whole host of such chemical mediators which can act, leading to tissue injury and increased sensitivity of the nerves. This is very important because there's a lot of study going on how we can control these particular chemical mediators. And these chemical mediators, if we can control, we can get better control of pain. What happens in the brain at the same time? There is another phenomena called as a central sensitization. Central sensitization is when there are physical changes in the brain. There is actual physical damage in the brain because of the arthritis, because of the continuous bombardment of painful stimuli from the joint. It comes to the extent where even a normal stimuli or a new sensation is felt as pain because it travels via the same pathway. A whole host of studies have been done in a similar manner, seeing people who have got pain because of arthritis, putting them in scanners, studying which parts of their brain do light up, and there's a whole host of it. It's also shown in some studies that the parts of the brain which control emotion, they are also activated along with the parts which control pain, which is a very interesting thing in patients with this problem. Functional studies have shown that there is physically reduced volume of parts of the brain in patients who are suffering from osteoarthritis, which actually indicates there is a morphological change in the brain. And it has been shown that there is increased connection between the parts of the brain which are involved in pain processing. So this picture here on the top shows a normal knee joint with a joint brain axis Like we have seen earlier with the movement in the pain pathway, the same thing happens in a normal knee. Now, what happens down here when the knee gets an injury? When the knee sustains any kind of injury, there are local chemical mediators, local stimuli, stresses, shear stresses, which start to stimulate these free nerve endings in picture A. This leads to the firing of these nerves and pain. At the same time, there is increased blood flow in these joints, which leads to swelling, inflammation, stretching of the tissues, and degeneration of the tissues. Also, because of the increased blood supply, the number of chemical mediators to that particular area increases. Over a course of time, this continuous repeated bombardment leads to damage to these free nerve endings, which itself get hyperactive and lead to pain. At the same time, the proprioceptors, which basically tell us our position sense, also get damaged, leading to abnormal loading, abnormal motor activity, change in the way we walk, and further structural damage within the knee. All this leads to osteoarthritis of the knee, which also affects the brain, leading to physical loss of volume and changes in the chemicals of the brain. Altered central pain, which is there in these patients, also leads to a different gait pattern. It is seen that the motor cortical area, if you do remember the map I had shown, the motor map in one of the slides earlier, there is a change in the position of a particular joint when there is severe central pain processing. That leads to motor deficits. Motor deficits means weakness in movement. There are altered gait patterns, which means the way you walk changes, and there are abnormal motor reflexes which also occur. All this leads to an abnormal way of walking, abnormal loading, increased damage, which further makes the pain and the problem worse. And it also leads to weakness of the muscles. Now, it's also seen that there is um, a chatter between the pain receptors and the um, proprioceptors in a joint, and these talk to each other and influence each other, causing worsening of the pain and worsening of the movement. Emotions. Like I had shown earlier, that studies have shown that parts of the brain which control a person's emotion are also active when a particular joint is painful. It has been shown that people who suffer from osteoarthritis of a joint, they show signs of depression and anxiety, and this is been well studied. This very simple study by Lee et al. Showed that when there is a painful stimuli which is applied to an already arthritic joint, it starts to fire up the part of the brain which controls emotion um, of the brain. So these people generally tend to have a higher state of depression. They are more anxious, and we see that commonly in our family. We have an aunt or an uncle or someone who suffers from joint pain and seems to be cranky all the time or seems to be depressed a lot of the time. This actually has a physiological basis. Cognition. What is cognition? Cognition, in a simple sentence, is what the brain thinks at a higher level. It is how the brain functions at a higher level, it's how it reasons and how it carries out tasks. It has been shown in studies that sometimes up to 25-30% of the people who suffer from any type of arthritis, they do have a problem in their cognition. They have poor cognition, which is possibly happening in them because of inflammation or as a direct result of their arthritis. Brain fog. Now, I've got a few patients who come to me. They come to me with pain in a particular joint. They have been diagnosed with rheumatoid arthritis. But one of their major complaints is that they are not able to concentrate. They are not able to think things through clearly. They have loss of memory. They can't remember date, time, etc. They can't focus on their work. This is brain fog. It has been studied and shown that people who suffer from rheumatoid arthritis because of the inflammation that is taking place in the joint. That same inflammation is affecting the brain, causing this brain fog. Also, the local chemical mediators which cause the damage in a particular joint cross the blood-brain barrier, get inside the brain, and cause chemical imbalance within the brain, leading to brain fog. Steroids are the mainstay of treatment for patients with rheumatoid arthritis. Steroids themselves have a direct result and a direct effect on poor cognition. A lot of the people just say that they are so distracted by their joint symptoms that they just can't focus on anything else. This leads to a lot of depression, leads to a lot of anxiety, sleep disturbances, mood alterations, memory loss in these patients. Also, these patients unfortunately have poor physical function, and a combination of poor physical function and osteoarthritis has shown to lead to poor cognition in patients. Osteoarthritis and dementia has an extremely strong correlation. And this picture here, if it, I'll just go back to the slide and explain. So why does osteoarthritis lead to dementia? There are indirect causes and direct causes. Direct causes is because of the inflammation and the chemical mediators which cause osteoarthritis and cause the pain in osteoarthritis. They cause the same issues and lead the same issues in the brain leading to dementia. Also, indirect causes are osteoarthritis is generally in population who is older. In them, it is seen that their age is a risk factor for dementia. A lot of these patients have got other associated problems like blood pressure, diabetes, heart disease, etc. And this itself is a risk factor for dementia. Similarly, some of the medications that are used by these patients, these medications also increase the risk of dementia by indirectly affecting the risk factors for dementia. And lastly, it is seen that the lack of any activity in these patients leads to more inflammation and dementia. So there are n number of reasons why it happens, but it is safe to say that cognition and dementia have a very strong correlation with osteoarthritis. Exercise, the brain, and the arthritis. I believe you all had a webinar yesterday which focused on the on exercises and its effect on the brain, and I cannot stress this enough. It is extremely beneficial for the brain. Regular exercises improves circulation in the brain, improves oxygenation, nourishes the brain tissue. Regular exercises causes a release of endorphins. Endorphins are chemical mediators which make your mood so much better, but they also have a role in reducing the firing of the nociceptors, the pain receptors. So they do control the nociceptors. Exercise improved blood circulation in the brain, removes the toxic chemicals from the brain, helps with the brain fog as well. It improves memory and concentration in these patients. But what happens in patients with arthritis? It's because of the pain, because of the poor joint balance and control, they find it sometimes impossible to exercise. So they do not get the positive effects of the exercise and in fact suffer from the poor effects of the exercise on their brain, which leads to mood disturbances, cognition problem, poor control of their other medical issues, and they'll end up into a vicious cycle. Treatment of arthritis. Now, in very broad terms, treatment of arthritis focuses on three factors: medication, exercise, and surgery. Usually, we start off with a combination of medication and exercise. The aim is to control the symptoms. Mind you that there is no cure. As we speak today, there is no cure for arthritis. There is research going on trying to cure it. There is no cure. But we need to try and control the problem, reduce the pain, improve joint movement, stabilize it so that we can prolong the life of the joint. If it does not work, we need to resort to surgery. But from a perspective of a brain, after understanding how the brain can also affect joint pain, a large body of research has been undertaken which studies on which has studied drugs acting centrally, and this controls the chemicals in the brain, giving out a signal of the pain being under control. And there is some fascinating research going on in the United States and in Europe on these agents. You've got some drugs which control the inflammatory mediators locally as well. And this also helps to control the inflammation in the brain and control your pain. Now, some of the creams you see which people apply, they contain something called as a capsaicin. Capsaicin is basically an active part of chilies. Yes, chilies. And when you rub that on your knee, you will feel hot. But that's how these creams work, because of the heat sensation, the brain gets distracted from the pain it's feeling, and it is perceived as pain relief. Similar such things are used in other creams which act locally on this site. But along with the medication, it's extremely important to remember the role of exercise. A graduated, focused, customized plan for each patient after discussion with the doctor is extremely important for them to get control of their pain. Tools like yoga, deep breathing exercises, meditation, etc., are very powerful and help in the central control of pain and help these patients get better. But at some point, we have seen that these things are not enough, and you do end up with what we call as a joint replacement surgery. In a nutshell, a joint replacement is basically where the pain generating parts of a particular joint are removed and they are replaced with these shiny metal and plastic bits. What this does is, because the pain generating parts are gone, there is pain relief, there is improved stability of the joints because of the new joint that you've got. This improved stability leads to a better walking pattern, better gait, better muscle control, and improved motor activity. There is a study which also actually shows very clearly that the degeneration which we have seen earlier, which occurs in a brain because of the disease process, can be reversed following a joint replacement surgery. And the benefits of having a joint replacement surgery are you have a pain-free mobile joint which works well. It allows you to do exercises, allows you to be free with your movement. This itself leads to improvement of your higher functions, your cognition, gets you better control of your depression states and your anxiety states. Because you're able to exercise, you have better control of your other medical problems like blood pressure, diabetes, etc. And this in turn leads to improvement of overall health. My take-home message from this talk today is very simple. There is a strong connection between our joints and the brain. Pain or instability can lead to physical and functional impairment of the brain as well. Arthritis affects not only a joint, but also affects cognition. It affects emotion and physical activity. And this in turn leads to poor control of other medical problems and worsening of your health. So when you have a joint which is in trouble, when a joint is in pain, don't ignore it, because a happy joint is a happy you. Thank you.
Thank you so much, Dr. Shah, for enlightening us. We have a couple of questions coming in from our audience. Vani Gupta asks, does the remapping or reorganization of the brain due to brain signals cause changes in walking pattern? For example, maybe less area to movement in the motor cortex, leading to stiffness.
Yeah, so what happens is when, because of the pain, because you have cortical remapping and rewiring, it does affect the motor cortex as well. So the area of movement in that particular, for that particular joint gets affected, and this in turn affects the way the joint moves. It leads to either instability or stiffness of the joint. It leads to mainly abnormal loading in the joint, and that leads to worsening of the problem in that particular joint.
Okay. Thank you. Chetna asks, she's curious to know if brain training like mindfulness, neurofeedback, and biofeedback combined with physiotherapy would impact the recovery or slow the progress of rheumatoid arthritis.
Sorry, I didn't get the question clearly. Could you repeat it, please?
So, brain training like mindfulness, neurofeedback, or biofeedback, along with physiotherapy, could have an impact on the recovery or slow progress of rheumatoid arthritis.
Um, Rheumatoid arthritis, we need to understand, is a autoimmune condition, which basically is where the body's own cells are attacking its own joints. Uh, Treatment or managing rheumatoid arthritis needs a multimodal approach. Medication is one part, but there's an extremely essential role to be played by physiotherapy, by mind control techniques, by psychotherapy techniques, which would alter again the same kind of wiring in the brain. It leads to uh, release of more positive chemicals in the brain rather than the ones that harm, and hence can help in the improvement of your rheumatoid arthritis state. But we do need to understand that this is a progressive disease. You are trying to control it, you are trying to slow its progression, but it is going to progress. Hence, it's extremely important to be dedicated to your treatment plan, not miss it, and use everything possible to you to get it under control.
Okay, thank you. There's another question. How is motor learning or skill acquisition post recovery in case of upper limb joint injury?
How is motor activity, or how
How
does
is
it
motor
happen?
learning or skill acquisition after the injury? How is the motor learning?
Okay, so after any injury, whether it be to the upper limb or to the lower limb, um, because of the treatment that you have taken, the treatment aims to get the joint back to a normal position. Because the treatment succeeds in getting the joint back to a normal position, the feedback from that joint to the brain comes back to a relatively normal state. Hence, the brain can start to understand signals in a better way. The cortical remapping, rewiring undergoes a change, and there is a and because of that, you get the correct signals that are sent from the brain to those joints. For example, if you have broken a bone around your elbow, and after it is healed, the sensation from the elbow of movement is now seeming normal to the brain. Hence, it sends the correct signal for correct elbow movement, which activates the correct group of muscles to do a particular job. If this doesn't happen, if the elbow heals poorly, then there is poor feedback. Poor feedback leads to poor output from the brain
Mhm.
and
Yes.
incoordinated muscle movement, and hence poor recovery.
Okay. Kajol asks, are there any side effects after the surgery?
Side effects after which surgery?
Yeah, after the surgery.
So side effects after joint replacement surgery, well, there are side effects of, well, you won't call them side effects, you will call them complications. They can occur
Okay.
with any surgery. Um, the minor complications are there could be delayed wound healing, there could be some persistent pain in the knee joint. Um, there can be sometimes you can get like a deep infection in joints. There can be loosening of those metal and plastic parts in a particular joint, which leads to more pain and poor walking gait. So yes, there are certain complications, but in well experienced, skilled hands, they are probably less than 1%. So they do have good results.
Okay. Neha asks, what can be done to a joint deformity caused due to severe post-burn contracture injury left for a long time?
Post-burn contracture injury has two aspects to it. There is a aspect in the joint and there's an aspect in the skin. Burns affect the skin depending on the degree of burn. Of course, you could be having deeper burns or superficial burns. The skin burns heal with scarring, so they lead to a contraction of the tissue, and when it's across a joint, it leads to contraction of the tissue and doesn't allow it to move freely. Hence, over a long period of time, the joint is held in a particular position, because of which it internally develops stiffness as well. Because if you're not moving your joint, think of it as a moving part of a car. If it's not moving regularly, it does tend to wear out. It does tend to become stiff. It doesn't work very well. So you need to keep oiling that part. You need to keep oiling your joint, keep moving it. But if you can't because of the burn, the joint becomes stiff because of contractions in the joint tissues as well. And the treatment for both of this would focus on treating the burn contracture and treating the joint contracture as well. The burn contracture would need to be seen by a specialist for that, who would need to understand whether any kind of surgery can be done. If the burns are healing all right and the contraction is very minor, then we can do joint surgery to try and improve the movement in that particular joint. But you should remember that you may never get back a normal movement as you had before that injury. But yes, there are surgeries that can be done to help that.
Okay. Uh, Dr. Taran asks, there is wide research work on generalization of learned motor activity. What is your take on the interlimb transfer of learned activity? It would have a great impact on sports-related injuries.
It would have a, sorry, the last line I didn't get.
It would have an impact on sports-related injuries.
Yes, so it all these mechanisms, all these feedback mechanisms play very positively in sports-related injuries, because you must understand a sports-related injury is an acute injury. It's a one-time event. It's not a chronic problem. You end up treating it well and you get the patient into a good program, strong rehab program, which will focus on every aspect of that joint. So whether it's movement, proprioception, whether it's joint stability, all that, if it's addressed, yes, this does have a very positive role and helps these patients with sports injury.
Okay, and is there a trade-off between the ability to learn and the injury between the injury?
Uh, I'm not aware from the top of my head of any study which um, does talk about this issue, but depending on the type of injury, motivation plays a big factor. How much the particular athlete wants to get back to playing a particular sport, that plays a very important role. Uh, this in turn leads to control of the central processes, and there can be a transference of these learned activities, which can affect these sports injuries.
Okay. There's a last question.
Yeah.
You talked about cognitive, the
Sorry, your voice is
work of
breaking up.
cognition.
Hello, can you hear me?
You were talking about, yes, I can hear you.
Yeah. Sorry.
Can you hear me?
Yeah. Yeah.
Yeah. You talked about cognition and arthritis. Have you come across any study that shows a direct link, or is just a correlation? Is there a cause and effect, or we've just seen a correlation? And is there any specific cognitive domain that is
Okay.
quantified?
So it's very good you brought this up, because there are studies which have actually correlated cognition with arthritis. They haven't studied a causal effect. Recently, there was a paper by the CDC which looked at a very large cohort of patients, and they concluded that it is probably not as significant a factor, but they do say in their study that the way they defined cognition and the way they defined the arthritis was probably not accurate. Having said that, uh, what actually caused this delay, I don't think that I've come across a study which actually links the two directly
Mm-hmm. Okay.
for now.
Okay.
But yes, but it has been seen that if you take 100 people who don't have arthritis and 100 do have arthritis, it is seen that there is a higher amount of a cognition delay in the people who have arthritis.
Okay. Is there any specific cognitive domain or just cognition in general?
I think cognition in general has been looked at. Again, I am not aware of any study which has looked at a particular domain as such.
All right. Okay. Thank you so much, Dr. Shah. It was such an honor to have you talk to us about
Thank
different
you.
pathways and how joint pain is recognized by the brain.
Thank you very
Thank
much.
you so much. And thank you, everyone. We end our second day of Brain Awareness Week with this. Tomorrow, we will be having Ms. Kavita Khanna talk about nutrition required by the brain at 11 a.m. IST. Do visit our website for more details. Thank you so much, sir. Thank you.
Thank you.